Our fourth speaker is Dr. Minny Ojha. Minny Ojha is a registrar at the Royal Adelaide Hospital. She did her MBBS in India and is currently looking to complete the CICM fellowship. Minny is going to speak on grade 5 subarachnoid hemorrhage, a single-centre analysis of patient characteristics, outcomes, and healthcare costs.
So my topic is a bit dark in comparison to all that's been said so far. I'll just launch straight into it. 5% of all strokes are subarachnoid hemorrhages, and the incidence is about 10.3 per 100 person years, with a hospital mortality of 29.2%, costing in the first year about $60,000 to $93,000. Now, most of that would probably come from the WFNS grade 5 subarachnoids, which are traditionally the most severe grade of subarachnoid hemorrhage. So we decided to study that and report it in terms of demographics, length of stay in ICU and hospital, costs incurred, mortality, ICU, hospital, and at 1 year, organ donation rates, and functional outcomes. So we looked at the ICU admissions in adults with the diagnosis of subarachnoid hemorrhage from 1st of January 2006 to 31st December 2016. People with the GCS of less than or equal to 6 was the WFNS grade 5. We looked at the CT scans for the grade 5s and excluded the traumatic subarachnoids. And the databases we used with the ANZICS adult patient databases held at the Royal Adelaide Hospital, the Brain Injury Rehab Unit, Registry of Births, Deaths, Marriages, and Donate Life SA. Comparisons were then made with grade 1 to 4, which is GCS less than, more than 6, and that was only to relay perspective. So the distribution of subarachnoids and grade 5s in that time duration was like that. Looking at the demographics, about 595 total subarachnoid hemorrhages, out of which 23% were grade 5. There was a female preponderance. Median age was about 56 years. Interestingly, only 10% of the post-surgical admissions, 10% of the grade 5s were post-surgical admissions, as compared to 21% in the grades 1 to 4. Perhaps they were a bit too unwell to undergo a procedure. 14% of the grade 5s had a cardiorespiratory arrest in the prior 24 hours, compared to 2% in the grade 1 to 4. And obviously, the risk of death, median risk of death, was much higher with the grade 5s, up to 0.71. Length of stay in ICU for grade 5s are about 5 days. Length of stay in hospital was about 9 days for grade 5. This is half of what grades 1 to 4 spend in hospital. The total cost, however, was roughly about the same, $42,000. Looking at the mortality, 55% of them died in ICU, and in hospital it was about 63%. And at the end of 1 year, only 64%. So the rise from hospital mortality to at 1 year mortality was not very much. Looking at the survival curves, first 3 days was where the most number of people died, and up to 2 weeks, many deaths. But if they survived 2 weeks, then they survived the year, was what we found. Looking at the organ donation rates, about 39 of the grade 5s were referred, of which 29 progressed to brain dead, and 1 DCD. Now, functional outcomes are measured as functional independence measure, or FIM, in almost all rehab centers across Australia. And so we decided to look at what we had from our rehab center, which is at Hampstead. So functional independence measure, the score runs from 18 to 126. It has a cognitive component and a motor component. The cognitive component consists of communication, social cognition, whereas the motor component consists of self-care, transfer, sphincter control, and locomotion. So now looking at the grade 5s, the motor component, there was a FIM change. FIM change means the discharge FIM minus the admission FIM. And the FIM change with the motor score was much higher for the grade 5s when compared to the cognitive FIM change, which basically means you can train the muscles. Physiotherapy is very useful, but training a cognitively impaired brain, our strategies are limited. Now, what do these numbers signify? Admission or FIM discharge more than 80 usually means they get discharged home. And if it's less than 40, then the discharge is to a nursing home. And in between is quite variable. So looking at discharge destination, out of the 139 grade 5 subarachnoid hemorrhages, 89 died. 5 went to a nursing home. We had some missing data there, but 24 went home. And of those who went home, only 6 were fully independent. The others needed carer support. So this is the only contemporary study on grade 5 subarachnoid hemorrhages. We looked also at hospital costs and at organ donation, which has wider societal benefit. And discharge destination was what we looked as outcome. We were limited, however, because this is a retrospective study and we had some missing data. Also, we compared grade 5 subarachnoid hemorrhages that were actually confirmed on CT scan to grades 1 to 4, which weren't confirmed on a scan. But that was to relay perspective, and we couldn't develop a prediction model. So to conclude, 2/3 mortality at 1 year. Most deaths happen in the first 2 weeks, and that too in ICU. In-hospital costs about $42,000 per person. 22% organ donors, mostly brain-dead organ donors, and only 4% survive to full independent living. Thank you.
Thank you very much. Any questions? Can I ask one question? You mentioned the societal benefit of those patients who become organ donors. I'm just wondering whether that actually balances at all the costs of prolonged treatment. Did you have any information on when those patients who became organ donors did so? Was it very early on, or was it after a week or so of treatment?
So most of the deaths are happening in ICU within that first 2 weeks. Most of the organ donation is happening at that time, because once they go to the ward, it's unlikely they become organ donors. So the first 2 weeks is fairly early in the piece that they become organ donors.
Yeah. Any other question? Oh, at the front.
Very nice talk. Do you have any data on the premorbid status of these patients? Because I guess what their premorbid status to some extent would contribute to their post-op recovery or post-event recovery.
So we did look at it without really trying to make any prediction model. What we found was the higher Apache scores, including removing the GCS component, seemed to have worse outcomes. So if they were physiologically unwell at admission, then their outcomes were likely to be poor. However, we didn't find any relation with age per se, but the Apache score definitely had some sort of connection, association there.
Anyone else have a question? No? I'll just ask another one as no one else jumping. One of the things that interests me in subarachnoids is the number of patients who come back to ICU, that they spend, first week, go off to the ward, come back for various reasons. Do you have any data on how those patients do? Are we investing wisely when we treat those patients for the second, third admission to intensive care?
So we looked only at the index admission, the first one. Just reflecting on what data we collected, there weren't many who came back for second or third admission. The number was very small, just from memory. We didn't look at those specifically, but the numbers were quite small.
Thank you.
All right, thank you very much.